From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Welcome, everyone, and Happy New Year. Good to have everybody back. We have so much going on here in 2018. I'm going to race through a few upcoming events before I introduce Carol Taylor. We have a few webinars coming up on Thursday, February 15th. Abdul Aziz Sahadina from George Mason University has a chair in Islamic Studies at George Mason, is going to be talking about the ethics of children's care from an Islamic perspective, or actually Islamic perspectives. On Thursday, February 22nd, Jenny Blumenthal-Barbie is coming up from Baylor College of Medicine to talk about biases and heuristics in clinical decision making and their impact on autonomy. That's going to be a great one too. We have a bunch more webinars, but those are the ones coming up in February. You don't want to miss either of those. We have been advertising a conference on pediatric bioethics consultation that we're doing in conjunction with our simulation laboratory. Unfortunately, that is now full, so if you were hoping to do that, I'm sorry, but we're hoping to do more simulation-based conferences on ethics consultation and on difficult conversations in the NICU, so keep your eyes out for those. Our certificate program for next year is also full, but if you want to get in on the ground floor for 2019-2020 academic year, now would be a good time to get your application in. And finally, I want to thank everybody who has supported this webinar program by sending in donations. Together we raised $5,000 last year to support this. We also get support from the Claire Giannini Trust and Children's Mercy here in Kansas City. So thank you for your support of these webinars. It is a great pleasure then to introduce friend and colleague Carol Taylor, who's a nurse and a philosopher, senior clinical scholar at the Kennedy Institute of Ethics at Georgetown University, Washington, D.C., where she's a professor of both medicine and nursing. At Georgetown, she directs an innovative ethics curriculum grounded in a rich notion of moral agency for nurses, particularly advanced practice nurses, and she teaches across the spectrum of nursing education. Also does clinical ethics consultations for 10 years, directed the Center for Clinical Bioethics at Georgetown, now happily has gotten out from under that administrative burden and back to the teaching that she loves. And she's going to talk to us today about who's not getting a fair share of health care and are we responsible? Thanks so much for coming.
Thank you, John, and thanks to my dear colleague Angie and to the Center for bringing me out here. For many reasons, this topic is near and dear to my heart. And I would just invite us to take a moment. In terms of this topic, an hour is nothing, but in terms of each of our busy days, an hour is a huge commitment. So why are we here in this moment? What's at stake? And I simply want to say, I don't think it could ever be more true that we live in interesting times. And I think whether you saw the Golden Globe Awards or not, we've all seen Oprah's speech and calls for her to be the next president. And when she said, I see a future where no woman will ever have to write #MeToo, my question to us is, could any of us with the same confidence say, we see a future where no one in this country will ever not have the conditions they need for optimal health care? What a stretch that would be. And how do we begin to change that? I find it incredibly interesting that Martin Luther King, who, if anyone, experienced inequality in this country, experienced some of the worst forms, whether it was job security, family, housing. For him to say, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. should make those of us who are intimately involved in healthcare sit up and take notice. And I was also surprised to learn in Bill Gates' commencement address at Harvard in 2007, he said, "I left Harvard with no real awareness of the awful inequities in the world, the appalling disparities that condemn millions of people to lives of despair." And then he says, humanity's greatest advances aren't its discoveries, right? That's where the incentives and the rewards are. It's like, let's all be innovative, let's make discoveries, but it's in how those discoveries are applied to reduce inequity. Reducing inequity is the highest human achievement. And so what I'm hoping this time together today is an opportunity for each of us to discern our individual calls to work on those inequities and how we might be part of the solution and not remain part of the problem. Simple objectives. In our short time, I'm really going to focus on the first strategy, which is personal awareness, and then responding to the call to utilize where we are and our resources to begin to be part of a positive change. So my first question is, do each of us believe that health disparities exist in the US? The first time I gave this talk, which was now 2 years ago, it was in a large system in Ohio, and at the end of my presentation, a physician stood up and he said, "I'm personally offended by your remarks." I was like, that's not usually the response I get when I speak. And then a nurse followed him and she said, "I'm personally offended." And the idea was they each believed they gave the best care they could to everyone who was in front of them, that they weren't part of this disparities. And I'm like, okay, how do I get to where we need to go? When their CEO stood up and he said, everything that Carol has talked about nationally is present in our system in spades. And so it may not be my individual bias, but it certainly can be institutional racism, institutional biases, because something is interfering with many of the people that we serve getting the care that they need. So do I believe that people like you and me every day are being treated in our best places and not getting a fair shake? I'd have to say yes. And I do that without trying to point a finger anywhere but right here. All right, it starts right here. You can all put your stories here. Adilma, the black mother of a 6-year-old son with asthma, she brings him to her pediatrician. One of the students I was just interviewing for our DNP program is a white mother of a 6-year-old son with asthma. Her son's best friend happens to be black mother, similar socioeconomic status. When the two mothers conversed after taking their sons to the pediatrician, the white mom comes home with an asthma kit that will help her to do everything she can to negotiate the future. Black mother does not. And she says, what's the difference? Why do I get the kit and she doesn't? Is there anything other than color going on? In my North Virginia background, the MS-13 gang is huge, known for cruelty. 18-year-old Jimmy arrives in the ER with a stab wound because of his tattoos, a suspected member of the gang. How does that affect how I respond to him and the care that I'm prepared to give? How about Marla, 55-year-old morbidly obese Caucasian woman admitted to the MICU with sepsis, placed on a vent. It was one of my advanced practice nursing students who said, we hated this woman, partly because of her obesity and the difficulty that she was in providing care. We all talked about her. And she said, to my embarrassment, I also talked and complained about her. And some of us complained in her presence. When she began to recover and was off the vent and could talk, they discovered what an amazing woman she was. And the student just shared the guilt she felt having treated her the way she did. And she said, I didn't know who she was.
And then lastly, my bugaboo are anybody who's older. So add in dementia, a man recently widowed, falls in the bathroom in his nursing home, appears in the ER, maybe incontinent, maybe cold. What motivation do I have to treat him with the same respect I would give to the person I love most? So some of us are pretty sophisticated consumers of healthcare. Many of us are not. And it always amazes me here in the US that when we articulated the principles of bioethics, autonomy is one of the four. Some say it trumps, although it was never designed to do that. But we were so intent on climbing out of the abuses of paternalistic practice that we didn't want to acknowledge vulnerability and responsiveness to vulnerability as a principle, which our European counterparts did many years later. One of my faculty colleagues, Barbara Aranda, is a Mexican-American nurse. She has a PhD. For a while, she managed the US global AIDS budget, very competent woman. She always said her biggest fear was waking up in the ER, unable to speak for herself, and receiving discriminatory treatment simply because she was Mexican American. That's a fear I don't know. So vulnerability wears many faces, some of them more obvious. Somebody came up to me after a talk recently and said, I'm glad that you don't simply show homeless, that you don't simply show poor, that you don't simply show abused, because the most vulnerable person may be the individual that looks just like you or me. So what I'm hoping to invite our reflection on are experiences, first, when we felt vulnerable. Because I think it's hard if we've not been there to get the experience of somebody who's afraid. December 1, it was a year since my husband's 4 to 5 hour major bowel resection. He was 87 at the time of that bowel resection. I was incredibly vulnerable. And post-operatively, his major plan of care was to get him moving, to get that bowel started. And if I wasn't there was no guarantee that the nurses would move. And he had so many lines. He was eager to walk, but he needed help. And I found myself not wanting to be critical because I didn't want to become the bad wife. And I thought, if I was reluctant to speak up, what about family members who aren't as comfortable as I am? And then to the extent that our eyes are open and we see people not being treated fairly, have we simply accepted that that's the way it is? Or do we feel the need to get involved? And I think that's the importance of culture. So again, if you look at the treatment of women in the workplace, for a long time, people accepted that that's simply the way it is. And there wasn't that need, or there was a real fear of retribution of speaking up. But it wasn't until people found their voice. I love thee in safety. We've done it, right? See it, say it. We've learned we've got to speak up, even if we're wrong. We're nowhere near that level of conviction when people aren't getting a fair shake. I always say, in every human encounter, people receive 3 messages. And it can be, your job, you mean nothing to me. You're an audience, you mean nothing to me. I'm flying back home tomorrow. I don't care about the time that we're spending together today. It could be worse. You're a miserable wretch. I'm in Kansas City, for God's sake. How did that happen?
We didn't tell you.
Or you're a person of worth and I care. And now the importance of this, the weaker we become, the more determinative those messages are. When I first started teaching nursing, the president of my college was a dear friend. At the age of 39, she was diagnosed with advanced ovarian cancer. She had a PhD in microbiology. She was from Worcester, Mass., delight, that sense of privacy and reserve. One of the most gentle, loving, wise human beings I've had the good fortune to know. She said, Carol, please tell your students, when I first got sick, it didn't matter how people treated me because I knew who I was. She said, as I've grown weaker, I become whatever people make of me. And she said, if a nurse or doctor walks into my room and treats me like meat, I become meat. And I wanted to cry that I remember my profession had the capacity to take a Lillian and transform her to a slab of meat on a platter by virtue of my approach. So one of the definitions of ethics that I love is it's the formal study of who we ought to be in light of our identity. And I think one of the questions we have to ask ourselves as health professionals is what is demanded of us. And that's what our code of ethics and our professional statements speak to. Good old Dan Callahan, in his Intro to Bioethics, identifies 3 questions at the heart of bioethics. And there's a real resonance to these. The first 2 are pretty obvious. Who do I have to be a good person? Second, what are my duties and obligations to those who are influenced and affected by who I am? It's the third question that I think we don't pay sufficient attention to, and it's the citizenship question. As members of society, what are our responsibilities? And if our societies aren't serving everyone well, what are our responsibilities? As a nurse, my code of ethics says in its first provision statement, we practice with compassion and respect for the inherent dignity, worth, and unique attributes of every person. So whether that's the member of the MS-13 gang, it's the person with dementia, unable to speak for himself. It's the woman on a vent with morbid obesity. And I do want to say, liar, liar, pants on fire. Because it's easy for me to say that. But when I ask an audience of 200 people, how many of you can say this is the way you honestly practice every day? There will always be a few hands that go up. But most of us know that there are certain patients that are much harder for us to interact with and to advocate for. So I'm not going to belabor these definitions. There is a fuller set of slides here than I will certainly get to in our short time this morning, and you're welcome to have those slides if you want. But obviously, with health equity, we're about attaining the highest level of health for all, not just for me and my family, but for everybody who enters this system. And disparities exist everywhere. I think we're all well-versed right now on the social determinants of health. If you think to that Robert Wood Johnson slide, it's only 20% clinical care that influences health state. When we take this knowledge and ask practicing healthcare professionals, how does this influence your everyday practice? That's where the challenge comes. There's a group now from the National Health Centers that have prepared this protocol for assessing risk and experiences. They have this beautiful assessment tool, and I've simply extracted some of the questions. But what do I know about the housing situation of my patient and family, their highest level of school, current work situation, whether or not they have insurance, whether at any point in the previous year they've been unable to get food, medicine, healthcare, phone. And if we knew these things, would that be influencing discharge planning in a very real and different way? I don't know how many of you are familiar with the ACEs project, probably in pediatric center, but I know in non-pediatric healthcare settings, this isn't common knowledge yet. But if we look at those 5 types of stressors, whether they're personal or familial, and realize that they have strong linkages not only to chronic illness, to depression, but to suicide, violence, and other problems moving forward. Many of these individuals are individuals that we don't like caring for. They're not the beautiful people. And yet, they may not be the beautiful people through any fault of their own, and yet they suffer because of the way I choose to respond when I see that. I think when I learned about this, the important thing about the initial ACEs work was it wasn't done in the inner city. It wasn't done with gang members, right? It's done with middle class, high school, college educated folks with health insurance. The new thing today in our interesting times world is this topic of immigration. And we lack consensus on where we stand in healthcare with people who are undocumented. I loved at the ASBH meeting Mark Krzyzewski's section where he said it's time to step back from politics. There's one of his DACA graduates who said, this isn't a Democratic issue, it's not a Republican issue, it's what do we in healthcare, what do we owe people who lack, and this sense that immigration is a stressor. In Washington, D.C., the Post this week was full of the news that El Salvador lost its protected status. And so we've got adults in this country for 20 years with jobs, paying taxes, owning a home, rooting for sports teams, having a Costco membership, and they may be deported. What does that look like? We've been asked to invite families who have concerns to talk to us because we're open to those conversations. What I've heard is that people have tried to use the sanctuary pledge, have in some instances been told to cease and desist. I tried to get this topic on a presentation to a board of a large hospice that I consult with, and the CEO said, Carol, take that topic off. It was a state, it's a red state, a lot of wealthy Republican board members, and thought that this would be not a good topic. There was a physician who said, this is not a matter that anyone can tell us to cease and desist. This is like attorney-client privilege. If we're healthcare professionals and immigration is a stressor, we should be able to speak about it with our patients. And what many people are now doing is passing out these types of cards to undocumented so that they would be prepared if they are approached. So then what are the responsibilities of a just and caring society? Because if we go back to the IOM report in 2003, if you remember, this was significant because they controlled for economics. They controlled for socioeconomic status. And they said, when we do that, it's people of color who experience disparities simply because they are a person of color. When we move forward to the 2012 IOM study, there were not significant changes. So 9 years of knowing that and the self-awareness hasn't begun to result in the type of changes that would make a difference. And they note that it's the institutional racism. And that's why I think we need this culture change. And again, I think the safety thing is a good thing to look at because we navigated that change. And it wasn't an easy. I grew up when we did not disclose medical error. And we still have challenges with that. But we are certainly speaking up about safety considerations. I don't know how many of you know Sally Benatar. It might have been the first ASBH meeting. Sally is a physician in South Africa and an ethicist, educated in Western medicine. And he did this session where he said, I always prided myself on taking the best care that I could of the person in front of me. And one day during apartheid, I realized it was always a white face in front of me, never a black face. And he said, when I began to speak to my colleagues about what we owe Black South Africans, the most common retort was, in the United States, they don't worry about disparities. Why would you hold us to a higher standard? And that was Solly's epiphany. And that's really the question that I wanted to leave us each with today. What's our own aha moment or epiphany? When do we kind of wake up and see that things aren't what they should be? And if that makes us recognize individuals or groups who aren't being served well, how are we going to respond? For whatever reason, my own personal epiphany was Ferguson, Missouri, and Michael Brown. And maybe it was because I'm an NPR groupie, and there were so many narratives of individuals in the community that I listened to and heard for the first time. When you hear a mother say, no mother should have to fear when her son walks out the door that he won't come back alive. That would never be my experience. What is that like? I serve on corporate boards with very excellent global senior leaders, physicians who are Black, who say, I get pulled over for a light, my hands are in the air. I get pulled over for a light, and I'm like, I hope I didn't do anything wrong. Am I guilty? I don't fear being shot and being dead. This is a very interesting time in our country. I love Nicholas Kristof, and he did a whole series in the New York Times about why whites just don't get the disparities and why they matter. This figure, to me, is appalling. The Black-white income gap in the U.S. is roughly 40% greater today than it was in 1967. This is the great U.S., and it's worse than it was in South Africa. This figure to me is staggering, and this is the 3 strikes and you're out because of the catastrophic experiment in mass incarceration. Black men in their 20s without a high school diploma are more likely today to be incarcerated than employed. Which doesn't even begin to get at the experience of Muslims, Mexicans. We at Georgetown always celebrate Martin Luther King Day. And 2 years ago, we were asked to reread his letter from the Birmingham jail and think about how we might use that in our teaching. Part of what most moved me was his writing about, as a parent, as a dad, having to explain to his 5-year-old daughter why she couldn't go to the amusement park that had just opened in town because Blacks weren't allowed. And he said, I began to see the clouds of inferiority fill her eyes. How do I respond to my son when he says, Daddy, why do white people treat Black people so mean? Now, as a white parent, I would never have that experience. And so, at the risk of overstating a case, I want to ask, are there similarities between what people and other individuals with vulnerabilities, people of color and people with other vulnerabilities, experience in healthcare to what people on the streets experienced during some of the rioting? We have not the best history here, right? If we think of Tuskegee, started in 1932, it didn't stop until 72. 42 years later, way after people knew it was wrong. But up until 2 years before it stopped, the CDC spoke to the importance and the validity of the study. I'm going to move to this question. Everybody has a right to health care. Everybody has a right to access. Everybody has a right to health care. Sadly, it's not acknowledged in this country. or it's a privilege which needs to be earned. Now, we answer that nationally. We each answer that individually. And it's always not consciously. I think it's no surprise that we have yet to accept the Declaration of Human Rights. The only industrialized country in the world is the US that doesn't offer some type of universal health care law. We're in a very interesting time of rolling back what the Affordable Care Act tried to guarantee. Tens of thousands lose their health care coverage due to circumstances beyond their control. So this isn't willful neglect. It's not, I want to spend my money on alcohol or gaming. A major reason we file bankruptcy is outstanding medical bills. And I'm not going to belabor these studies, but when we look at international studies that compare the US with our European counterparts, we're often at the bottom of the list. So even though I may be able to purchase good health care for myself and loved ones, that's certainly not true within the US for people at large. That goes back to the 2012 ARC study. While blacks received worse care than whites in about 1/3 of all quality measures. Now, you're not going to probably be able to see this, and I'm going to do this real quickly, but we're all vulnerable as humans, right? I'm just recovering from the flu. I felt pretty vulnerable. So we're subject to harm. If I can accept that I'm vulnerable, and my vulnerabilities are met with empathy, compassion, somebody's committed to move me to a better place, and solidarity, I can flourish, not only in spite of, but because of those very vulnerabilities. If, on the other hand, I'm vulnerable, and I can't accept that, so I don't allow anybody to help me, but I'm met with indifference, with bigotry, with hatred, I'm going to feel isolated, and there will be a failure to thrive. It's that simple. And that's the difference we each make individually, and we each make in our health systems. We each make in our units. And it's what makes that opening question, who's not getting a fair shake, so critical. And if we go back to Dan Callahan's third question, fundamental question in bio, what kind of society do we want to be? And what kind of a society do we want to create for our children? The increasing disparities in this country ought to be a source of concern. With my political leanings evidenced, I'm going to go back to President Obama's 2012 State of the Union address. We can either settle for a country where a shrinking number of people do really well, while a growing number of Americans barely get by, or we can restore an economy where everyone gets a fair shot. Everyone does their fair share. Everyone plays by the same set of rules. As somebody who lives in Washington, D.C., probably my favorite part of the tidal basin is the FDR Memorial. It's pink granite, lots of flowing fountains, and you walk through the different stages of his presidency, and you see the bread line during the Depression, and etched in the granite is this statement: I see 1/3 of a nation ill-housed, ill-clad, ill-nourished. The test of our progress is not whether we add more to the abundance of those who have much, it's whether we provide enough for those who have too little. I think that ought to be sobering. And if we couple that with Bill Gates' insight in the 2007 commencement address at Harvard, what's important about discovery and innovation is how we use it to address these disparities. I love the hear no evil, see no evil, speak no evil. And that's a pretty comfortable posture. And it's a posture that maybe has served seemingly too well for too many of us in healthcare. As we go our merry way, earn our salaries, busy ourselves, working hard every day, doing good stuff, but maybe missing the needs of those front and center who are objects of our responsibility and care. The IOM report concluded that a significant barrier to eliminating health disparities is a lack of awareness of the problem on the part of key stakeholders. There are national strategies now to engage boards. We're doing a lot more with senior executive teams. We're certainly trying to get payers involved. But I believe that we each have a role to play. And unless we can speak our individual truths and utilize the resource and leverage we have to make a difference, we're going to be looking at the same numbers, perhaps worse, in the next decade. Denise Thornby used to be president of the American Association of Critical Care Nurses. And she was famous for exhorting critical care nurses to make waves when they discovered that healthcare wasn't working for the individuals and families and communities they served. And she used to quote John Quincy Adams, that she said, each of us is creating our own type of immortality by virtue of what we choose to do, who we choose to be every day. And she used to say, each of us is experiencing a call to courage. And she said, courage comes from the French word cœur, meaning heart. You've got to care about someone to be moved by their plight and moved to action. And so I want to end asking us each to think about, where are we being called to make a difference for people who have not been able to advocate for their own vulnerabilities and needs being addressed. I'm going to stop here. Would love to take your responses and if anybody has questions.
Well, thank you so much. That was truly inspiring and a little frightening. For those of you watching online, if you have a question or comment, you can either type it in that little chat box at the lower right-hand corner of your screen, or you could tweet us at #CMBioethics. We'll read out those questions from either the WebEx chat box, or we'll be monitoring your tweets as they come in and read them out, and you can ask Carol questions. People in the live studio audience here also feel free to ask questions. I have a couple to start with. First, probably most importantly, do you support Oprah for 2020?
As you heard, right? She hasn't even considered running.
So you're holding off on that.
I'm holding off on that.
Okay. Second question. As you talked about all this, it seemed clear that there's sort of problems at the individual level, problems at the institutional level, and by that, I think you were referring to hospitals or healthcare systems, sort of intermediate institutions, and then problems at the societal level.
Right.
And some of the problems come from policies that are explicit. I mean, we changed the tax code and it increases disparities. Some of them are more implicit, like we are unaware that our institution may be doing things that exacerbate disparities. How can an individual figure out in that complicated sort of matrix of disparities, racism, and everything, what can I do? What am I doing wrong? What could I change?
Okay, I always say, first at the level of the individual, it can be really refreshing to the extent that we can, float above our place of work and look down with fresh eyes, not the eyes of, this is the way we do it, we've always done it this way, to kind of what's not working. It should make a difference to me if I'm at Georgetown University Hospital and I go into our maternity clinic, and there are no faces of color. And I know that while we live in a wealthy neighborhood, there are certainly people of color in our neighborhoods. And I have to say, what's going on there? And then when I hear a graduate student who works across town at Providence Hospital with an inner city population, and she's now working at Georgetown, and she says, you know, Carol, where I used to work, we gave women a reason to come back. We helped them address their challenges in getting the healthcare services. And I'm not feeling that we're doing the same thing at Georgetown. That should be a flag for me, that something is amiss, and then we need to begin the fact-finding that could say what accounts for those differences. And that's always, when we talk about participatory research, right, community benefit, that can't be me as a white woman trying to presume what the challenges are. It means finding out from people who could be utilizing our services and aren't, why they're not there and what we need to do to change. So I think, and that's why I say awareness is the first piece, but then it's looking at those layers of things that are influencing what's happening. If we do that fact finding, then we're going to look at some of the national reports, because there is a lot of good work done. And we haven't begun with translational research to begin to mine that data to make a difference in our practice. And it's also what becomes the institutional priority. And here's where I think boards have to get involved. Because if we're not charging senior leadership with addressing the disparities, then they're happy, because they're going to deliver what we say they need to deliver to reach their incentive goals. If we say, you know, we want disparities to be front and center, then that's got to begin to happen. So I think key leadership needs to be on board. And if I work for you and you're the head of the center, if I say John doesn't care about disparities, then, well, unless it's really a passion of mine, I'm not going to care about disparities either. But if I know that disparities are your thing and I want to be happy here, then I'm going to find a way to make, does that make?
Yeah, it's a little tricky, because, I mean, taking your example of, let's call one place, Georgetown, we'll pick a place there. And the other place, what was it, Providence?
Providence.
Providence. I mean, one thing that somebody could do would be to say, I'm going to go work at Providence.
Yes.
Because the institutional leadership there seems to share my values, and the institutional leadership at Georgetown doesn't. That in some ways is harder, assuming that maybe the work situation is more difficult there, the resources aren't as luxurious, in part because of their mission of serving the poor, which has an effect on the bottom line. But in some ways, it's harder to stay at Georgetown and become a troublemaker, become a whistleblower, become an advocate.
Okay, I want to go there.
Okay,
I do
let
want
me
to
remind people, write a comment or a question, or people in the audience. Yep, go ahead.
Okay, great. I want to go there because in terms of organizational integrity, and just using this example, this is my hospital. Georgetown is a Jesuit Catholic university with a huge commitment to social justice.
Right.
So you can't say it's okay that we're ignoring the needs of the most vulnerable. And there may be reasons why it's more difficult to address them. And there can be a lot in conflict. If I'm a wealthy woman with my one pregnancy and I want to come into a clinic and see people who look exactly like me, Georgetown might want to cater to me, but at the expense of its integrity. And that's why I want some troublemakers. And that isn't an easy role to play. And it sometimes means asking people to be honest about who we say we are. And that was my definition of ethics. Who do we say we are? What is it reasonable to expect of us? And if it's not treating everybody the way they should be treated, then boy, I want people who have the courage, and that's where that call to courage comes in, to be committed to trying to stick with the issue and make the changes. And you may be slapped down many times before.
I was going to just bring up real quick, Carol, and you kind of grabbed onto it at the end, is that when we hear those stories as individual nurses or individual employees of our of our patients, our families, we need to have that courage to bring those stories forward, because we're always told it's the stories that
Yes,
give people to move beyond
yes.
from where they are. And I think we have to have the courage as employees or as nurses at the bedside, when we see the stories or hear the stories, to bring them forward to leadership. It may be not the leadership at the top, but it's that next little step. And I think that's hard. And how do we help young nurses, young health professionals to be able to do that?
Yeah, I couldn't agree more.
We have a question from the online audience. This person is wondering, they're a school nurse, and recently a decision was made at their school by a different department to not share information with the nursing staff about the housing status of students. And of course, the nurse mentions that they use that information to inform the care they provide, and was wondering if you had any thoughts on how, are there other statements or information that you could share that would convince this nurse to share with her department colleagues that why the importance of nursing having this information. So she mentioned, of course, the reasons why she thinks it's important, but maybe if you could help bolster her argument.
Right. I mean, I would definitely, and the website is on the slides, but that prepare the protocol for assessing risk makes that very clear, why that information is essential to good health care. The ACEs project is, again, another one. But that data, I'm sure I'm trying to understand the reasoning why they would want nurses not to have that information, because it's absolutely critical. Those of you, I'm not in the pediatrics world, some of you might have better resources that you can point to.
It could be each district has their own rules, and this is from working with school nurses, but then also the state, and it could be depending on if there is privacy, but there have been some things that have come down in the states that we happen to live in here, where due to the social resources and the requirements for those, it's made it more difficult in getting that information, and that may be what she's referring to, and how can she try to bring information forward, is what I'm guessing.
Yeah, I don't know if that person that asked the question wants to write in and provide more context. We'd be happy to look at it. I do have another question from online, and that was, have you seen any change over the past 2 years that you've been addressing this issue? And I'm guessing you've been addressing it for more than 2 years, so take into account whatever time period.
I think the biggest change that I would say simply is people on an intellectual level are more familiar with the topic, but I don't think we have owned the topic yet. And that's why there's not the reluctance or not me, I couldn't be involved in this. I'm not seeing that as I did when I first started speaking about this, but I haven't seen it owned in a way that is making practical difference in clinical sites. And that to me is the tragedy. But I'm an optimist, and that's why I say we've been in bad places before, and with some pretty awesome cheerleaders and a lot of hard work, we're getting to better places. I think we have to get to a better place with this. And I'm just, this is another bad personal sharing. I would never characterize myself as racist. When my husband was diagnosed as needing this surgeon, after a lap, the chief of cancer surgery at Georgetown said to me, Carol, and he knew me, he said, Carol, here's who I'm recommending. So I go home and I look up this physician. He was from Nigeria, did medical school there, did his medical degree at Howard, which is a black university. I didn't see ratings on him, and I'm like, this is the man I love more than anything in the world. I want the best person to do this surgery. And so I went back to Dr. Al-Rafi, and I'm like, should we be going to MD Anderson? Should we go into, and he said, Carol, I wouldn't have recommended him if I didn't think he was the best person for you. And he said he did his fellowship at Wake Forest, where they do a lot of these surgeries. He said, I want you to meet him. We love this man. But I could very easily, on the basis of my own bias, have said no to him because he was educated in Africa, and I didn't equate that with the U.S. medical education. He was black. very black. He was the nicest surgeon in the world and the most skilled. And my husband is alive because of this man. But I was appalled at my own response. And I think we need to get to, what is that? That's the unconscious.
It's an amazing story to share, and thanks. A lot of people wouldn't have noticed that about themselves, but let me highlight the way you told it in a way that I think addresses this thing that everybody has trouble with, the difference between individual and institutional racism. When you questioned about whether this was the guy your husband should go to, you didn't say, wouldn't a white doctor be better? You said, shouldn't we go to MD Anderson?
Right, exactly. Yes.
A statement that nobody could have suggested was a racist statement. Everybody thinks about going to MD Anderson. But in your case,
right,
as you told it, the reason was concern about the color of the doctor's skin. Do other people have aha moments? I mean, the epiphany moments, it seems to me, are crucial to this story, either here or online. Go ahead, Sean.
This was very eye-opening.
You have a microphone.
This was very eye-opening for me. I think the challenge we have is not the resources to care for everyone. The challenge is our knee-jerk reaction, not here, not us. And I think that's what we do until we really start. And it's extremely uncomfortable to take a real good look at yourself and where you work. And that's our challenge, I think. We have the resources to care for everybody the same way. But will we?
Do you think issues arise in the PICU?
Absolutely.
Can you think of
I think issues arise in our cafeteria. I think issues are everywhere. It's just, are we willing to take the time out of our busy day? And are we willing to really look at ourselves, because it doesn't feel good. It doesn't feel good at all. And we justify our behavior too. And we probably have to stop that.
Who wouldn't go to MD Anderson?
Absolutely. Absolutely. Yeah. Yeah.
I know that one of the ways I justify is by thinking about the difference between what might be called racism and what might be called cultural sensitivity. So if I have a family from Ethiopia who I'm seeing in the ER and I need to get the Amharic translator on the telephone, I know that my explanations of disease processes are going to be quite different than they would be for a white middle-class family. How much of that is appropriate? How much of that is my assuming that these people are uneducated and don't have the understanding? I don't know.
So my nurse practitioner student in the neuro ICU, confronted with this topic, she said, I was called to my hospital because her uncle was a patient. And she said, I was appalled in the family meeting at the language that was used to describe his condition and the way our family was treated. In spite of the fact that she was a neuro ICU nurse practitioner, the expectation was that they wouldn't understand the medical term.
And she was black.
And she was black. And the family was black.
Right. But yeah, I mean, that's I think the most common sort of pervasive, institutionalized kind of racism that I see. And
I think that was the asthma toolkit, right? There was an assumption made that this family wouldn't benefit. And I just remember my student being so appalled because she knew the mother, and she knew the family, and knew that she was every bit as competent in utilizing that kit to the advantage of her son as she was, but it wasn't an option that she was offered.
one of the things that's most interesting in a lot of the studies of disparities is it doesn't matter if the doctor is white or black.
Yeah.
That sort of, it just pervades the cultural things overwhelm individual things. Yes, another online question. You can type them into the little box, the chat box. We want to hear from our online audience. Go ahead.
This online question is regarding whether or not, how do you think it would reflect upon an immigrant if they asked for their rights related to healthcare? And that's, you can just leave it at that. Would it reflect poorly upon them?
If they asked for their rights, I think it would depend on the receiver of the request, right? So, I mean, I can think of people, healthcare professionals, who would say, you've got no rights. You know, what are you expecting? And that's where that sanctuary pledge, that's an amazing website, the Sanctuary Doctors Pledge. But they're a group of people who are looking at immigration status as a stressor, how that affects health, saying, you know, we've got to know about this and we've got to be prepared to help people. So I would hope it would be met with a, let's talk about what is reasonable for you to expect. But that goes back to those challenging questions in ethics, right? Who's entitled to what? Is the moral status of somebody who's undocumented different than mine? Are they entitled to less here in the U.S. than I am? And should that, if even the rest of society operates that way, can we afford to operate that way in healthcare? And that's where I think we're judged, because we've seen a lot of complicity internationally by healthcare systems in the U.S. and elsewhere where we participated in unethical programs. And I'm not calling out or limiting that to Nazi Germany. It could be our own U.S. eugenics history.
Or Guatemala.
Guatemala, right?
I hadn't been aware of that sanctuary pledge. Do we use anything like that here? Yeah. Does anybody online, have people use that? Go ahead.
I'm not sure about that specific question,
Go.
but we do have another question, which is that they're wondering if there's a role for hospital ethics committees to address social justice issues. An employee is seeing a trend, for example, mistrust in healthcare about being honest with minority populations.
Mm-hmm. I mean, I absolutely think there, and here's where, if you did consciousness raising, you would hope that the ethics committee would be getting requests for consults from staff who are aware of challenges. And the way ethics committees work, if those begin to number, then the ethics committee is going to bring those forward to powers that be, saying, you know, there's increased awareness of instances where we're not getting this right or doing it well. What changes can we begin to make? But I would love to see an ethics committee, if you haven't begun to address this topic, do some self-education on the committee and think about the messaging that people are receiving that work in your place.
So we need to wrap it up. Let me just point out for people who didn't notice, the complicated slide about vulnerability and resilience came from a book edited by Carol Taylor called Health and Human Flourishing, Religion, Medicine, and Moral Anthropology. It's in very small print down there at the bottom. Carol's also edited a couple of other books, Fundamentals of Nursing and Case Studies in Nursing Ethics. So if you like this talk, go out and buy the books. They're wonderful. For those of you who are local, Carol's going to be doing an ethics brown bag lunch at noon in the auditorium at Children's Mercy on the Adele Hall campus. That will... And a certificate of attendance for this is available on our website. So if you attended and would like a certificate of attendance, you can fill that out. Please join us Thursday, February 15th, when Abdulaziz Sahadina, Chair of Islamic Studies at George Mason University, will be talking about Islamic perspectives on pediatric bioethics. Thanks again for coming all the way to Kansas City and treating us with such respect.
Thank you. Thank you.